Hello, Christine.
Hi, Josh.
I feel like I know this course is taught throughout the year. I feel like we should only learn the cardiac system around Valentine's Day, though.
You're such a romantic.
I've always been known as a romantic. That's
I feel like every day is Valentine's Day for you, no?
most days are.
All right,
I give a lot of love in the world. I get a lot of love back.
right.
I love teaching and I love teaching about the cardiac system. Hopefully we'll just do a quick anatomy and physiology review. Uh, so the heart is it's it's the pump of blood through the body. So it's two sides to it, right and left sides, double-sided muscular pump. There's four chambers, two atriums, two ventricles, atriums on the top, ventricles on the bottom, right and left. So you have a right atrium and a right ventricle, a left atrium, and a left ventricle. There are valves to prevent backflow into each chamber. We'll to look at some valve disorders later when those valves don't work well. So the AV valve, atrioventricular valves, tethered to the ventricles via the cord tendonae. We have tricuspid and bicuspid valves. The bicuspid is also known as mitral valve. So sometimes on exams or in textbooks, it can get a little bit confusing if the student only learns bicuspid and then all of a sudden they're reading about mitral valve and they're saying, where the heck is the mitral valve, right? So those words are used interchangeably. The tricuspid separates the right atrium and right ventricle. The bicuspid is on the left side. And again, that's also known as the mitral valve, and that separates the left atrium and the left ventricle. I remember the mitral valve is on the left because there's an L in mitral. That's the last letter of mitral. We also have semilunar valves, so that separates the right ventricle from the pulmonary artery, and the aortic semilunar valve separates the left ventricle and the aorta. So the blood flow of the heart, blood flow enters the heart via the vena cava, either the superior or inferior vena cava. That deoxygenated blood gets dumped into the right atrium. The right atrium then pushes it once the heart contracts, it pushes it into the right ventricle through the tricuspid valve. That tricuspid valve will then close to prevent backflow. The right ventricle on the next contraction will then push its deoxygenated blood into the pulmonary artery through the semilunar valve. The blood then is transported into the into the lungs to pick up oxygen, and it also releases the carbon dioxide that's within that blood. So that's where the gas exchange happens. The blood goes from the lungs back to the heart through the pulmonary vein, and the oxygenated blood enters the left atrium. Then it goes into the left ventricle through the bicuspid, again, also known as the mitral valve. Then the oxygenated blood enters the aorta, then is the left aorta, the aorta, and then it's through the semilunar valve. And again, that's to prevent backflow. Now, one thing that I will point out that is really unique to the heart system, arteries have oxygenated blood going away from the heart, and veins have blood that returns to the heart. So the one interesting thing about arteries and veins, again, arteries away from the heart, veins to the heart. The pulmonary artery is the only artery in the body that holds deoxygenated blood. And the pulmonary vein is the only vein that holds oxygenated blood. So that's pretty cool. So the blood supply of the heart itself. So the first thing that the first thing the heart wants to do is feed itself, because the heart's really important. So the first branches of blood vessels off of the aorta feed the heart. So we have right and left coronary arteries. They then branch into left anterior descending artery, which supplies the anterior walls of the ventricles and anterior septum. We have the left circumflex that goes around the heart and supplies the left atrium and part of the walls of the left ventricle. So we also have the right coronary artery, which supplies the right side of the heart, part of the inferior aspect of the left ventricle, and the interventricular septum. So the great thing about our coronary arteries, it's really important that it has collateral circulation. That means that there's alternate pathways for blood to travel. So that is, if we have a blood clot or a thrombus formation in one artery, some of this collateral circulation can counteract that, can balance it. It's a good safety mechanism for it. Different layers of the heart, the endocardium, myocardium, and pericardium. Endocardium, inner lining, squamous epithelial cells. The myocardium is the thick muscle. That's the thickest part of the layers of the heart. Then the pericardium is a double-walled sac that surrounds all three layers. The nervous system of the heart is important to know about. So we have no nerves in the cardiac muscle, but there are discs between fibers that quickly transmit nervous pulses. So that's an interesting aspect of the cardiac muscle cell itself. Let's look at the conduction of the heart. So the conduction of the heart starts at the SA node, sinoatrial node. That's where the impulse, the nervous system impulse, gets sent to the SA node, and then it starts transmitting a signal across the heart when to contract, when to relax. The signal then travels to the AV node, or atrioventricular node, and then it's going to go into the bundle of His. And then from the bundle of His, we're going to break out into the left and right bundle branches, again, depending on where the nervous system wants to affect the heart. And then the terminal fibers are called Purkinje fibers. I just like thinking about Purkinje fibers. The neural control of the heart has to do with baroreceptors. So those are baroreceptors monitor blood changes in the heart, send signals to the medulla. The medulla sends either sympathetic or parasympathetic nervous system. Again, the sympathetic nervous system is the fight or flight, will increase heart rate. It will also increase the force of contraction, release epinephrine and norepinephrine. The parasympathetic, rest and digest, slow everything down. So the baroreceptors get to tell us what to do, and it helps change how the heart functions because of the blood pressure. When we talk about the contraction versus relaxation of the heart, diastole is the relaxation phase of the heart, and systole is the contraction phase. When is the heart squeezing? When we listen to the heart, when we use our stethoscopes and listen to the heart, we'll hear the lub-dub sounds. I don't think that's on page 82. That was a different textbook that I was using. So we have different sounds we can hear. I don't think that's important for our class right now, but as we get into, especially into the more acute settings, hospital type settings, you might see in charting S1 sounds, S2 sounds. Those all have to do with the valves closing. And actually that lub-dub sound we hear, that sound is actually the valve slamming shut. So that's pretty interesting. So again, more abnormal heart sounds. I don't think it's important for this class, but should you come across it as you're doing chart reviews, that might help you. So what do we already know? We know how to assess pulse. Heart rate is measured in what units? Beats per minute. Usual sites for taking pulse: brachial artery, radial artery, sometimes carotid, although there's a lot of baroreceptors in the carotid artery. So with our palpation, if we're inexperienced with palpation, as we kind of mess around and try to look for that area, we might be stimulating those baroreceptors. And if we stimulate those baroreceptors, we're going to be changing what the heart rate is. So I like to stay away from that as an area. But definitely the brachial artery, especially when we're taking blood pressure, we need to put the bell of our stethoscope on that brachial artery. Other information we attain with our pulse when we're doing a formal pulse assessment, not only the number of beats per minute that the heart is contracting, but also what does the force feel like? What does the rhythm feel like? Rhythm will tell us information about the nervous system of the heart. And then the force is going to tell us just how strong is that contraction. Stroke volume and cardiac output. Stroke volume is the amount of blood pumped per contraction, the amount of blood pumped from one ventricle during contraction, which should be about 70 milliliters. And then the cardiac output is the amount of blood pumped out by the ventricle in a 1 minute period. Resting cardiac output should be about 5 liters per minute. So if you love math, the great thing about the cardiac system, if you want to go into treating with the cardiac system, it's very mathematical. It's very rigid. You get to measure the heart and do an exercise to change the heart, and we can see it right away. So the formula for cardiac output, well, cardiac output depends on how much blood is squeezed per beat. And then we can also change how many beats we have per minute. So it's a wonderful way that we could look at cardiac output. Blood pressure is the amount of pressure exerted against the walls of the peripheral arteries or systemic arteries. So systolic blood pressure is the top number when we read blood pressure. It is the top number, and it's when the heart is contracting and the arteries are under its most amount of pressure. The diastolic is the bottom number, and when the ventricles are at its rest. So if the norms are 120/80, that means it's 120 millimeters of mercury. That's what we're measuring when we're doing our blood pressure readings. That's the systolic pressure. The diastolic at rest is the 80. With exercise, blood pressure should go up. So systolic blood pressure should go up in relation to the intensity of exercise. The diastolic should be unchanged. Most textbooks say no greater than 10 millimeters of mercury difference with exercise, but it should stay very close to the same. There's a couple of videos if you want to look more into the blood flow through the heart, listen to heart sounds, look at the electrical system of the heart or the baroreceptor. So if all of this is very foreign to you, you can look at those videos that can help you out a little bit. Blood pressure should vary. It's going to vary at times a day, and of course with exertion, like we just talked about. The blood vessels we looked at when we do the blood and circulatory system, you can look at that. Other thing to understand, lymphatic system recirculates excess fluid back into the blood. So part of that system, lymph nodes, the spleen, thymus, lymph fluid, and the other lymph vessels. Some tests that are common with our cardiac patients, you could do cardiac catheterization and angiography, looking at how the blood flow through the heart is, echocardiography, electrocardiogram. You could look at Holter monitors, so that's a monitor that the patient wears, usually at least for 24 hours, and then you can look at how the heart works throughout the day. Different laboratory studies, blood and urine, mostly blood. PET scans and different stress tests. So having our patient perform exercise while being closely monitored. And here's what that electrocardiogram is. So if you've ever seen a movie or a TV show of a hospital, they're hooked up to machines and you see the lights flashing behind the patient on a monitor and you hear the beep, beep, beep. So that's what we're looking at, the electrocardiogram. And what this is the electronic readout of the heart and which fibers are contracted, which aspects of the heart are contracting, and then when they're at relax. So the P wave here is depolarization of the atria. That's when the atria is going to contract. The QRS complex here is the depolarization or contraction of ventricles. And then the T wave over here is the repolarization of ventricles. So we also have the PR intervals, PR segments, ST segments. And one of the useful things about electrocardiograms is if this ST segment is elevated, that means this line kind of goes up on the screen, that would indicate an acute heart attack. If it's depressed, where this line is low, that would indicate an old heart attack, something that happened, months or years ago. So that's how you would use it, EKG or electrocardiogram. So hopefully that was a good review for you on the anatomy. And we will pause this. We'll come back in just a little bit, start talking about pathologies.